Welcome to the Faith and Gratitude Speaker Series, an educational program designed to bring you new insights on cancer wellness. We focus on practitioners and specialists that have an integrative, holistic approach to treating cancer and want you to have the opportunity to hear their views firsthand. The series is part of our ongoing commitment to providing empowerment and education to cancer patients during treatment and beyond. Today, Dr. Mark Rosenberg, founder of Advanced Medical Therapeutics, will share his thoughts on integrative oncology from both a research and clinician perspective. His comments touch on the issues patients can sometimes face navigating today's medical community and brings to light the importance of being your own advocate.
Hi everybody, I'm Mark Rosenberg, and I want to thank Faith and Gratitude for having me here and filming me. Let me start by telling you a little bit about my background. I'm here to tell you about what I do with integrative oncology, meaning treating patients with cancer from an integrative fashion. My board certification actually is not oncology. My residency training and board certification was in emergency medicine. I went to University of Pennsylvania undergraduate school, and then I went to Georgetown University School of Medicine. And like many of us at Georgetown, because it was so expensive, the Army put me through residency and medical school. And so my formal training was emergency medicine and really toxicology. And I completed my time with the Army as Assistant Chief of Emergency Medicine at Walter Reed Army Medical Center. Then I ended up moving to Florida, and about 19 years ago, while I was running an emergency department, my own mother walked in, and I diagnosed her with metastatic non-small cell lung cancer to liver, spleen, bilateral adrenal glands, and left hip. And it was on me. I was the one who had to give her this message. And so, of course, about 19 years ago, I didn't know anything about treating cancer other than managing an acute crisis in the emergency department. So I brought my mom up to Philadelphia, and that's where they explained to me that with all our drugs, our chemotherapy drugs, my mom would likely live maybe up to 6 months with chemotherapy, maybe 4 months without chemotherapy, or maybe still 6 months. So they explained to me that chemotherapy likely extended survival for the advanced stage solid tumors by about 2 months. And I was blown away by that. And realizing that, of course, some people can get very sick from chemotherapy. Do you want to get perhaps an extra 2 months of survival and have it be a miserable quality of life during that time? So my mother refused chemotherapy, and so I don't think I slept for 3 weeks. I hit the literature, and I presented to my mother all the treatments I could find around the world, not knowing really, having no experience treating cancer. My mother said she'll take intravenous vitamin C, which I knew nothing about at the time, and that's all. She ended up living 11 months, and really most of that time was good quality of life. After my mom passed, that's really where my journey began. I really started investigating the literature, and I actually started treating some patients and eventually left the emergency department, which was my formal training. And I will never forget what one of my mentors told me, he's a board certified hematologist oncologist, very, very bright guy, but he also does integrative medicine and integrative oncology. And he said, Mark, be careful, because I know you're really trying to understand the science of cancer and trying to improve treatment, but it'll suck you in and it'll become your life. And that's what's happened. It has become my life, researching cancer and just reviewing the literature. Now, I do want individuals to know that despite what you may hear as far as our improved survival by our better treatments, unfortunately, for most advanced stage solid tumors, our improvement is minimal. So on August 3rd, 2022, there was a publication in the Journal of Clinical Oncology. And what the investigators did is they looked at 124 drugs, new drugs that were FDA approved between 2003 and 2021. So the investigators looked at, did these drugs improve progression-free survival and or overall survival? And if so, how much did they improve survival over best supportive care? And they found that progression-free survival improved by a median of 3.3 months, and overall survival improved by 2.8 months, which is astounding. Perhaps we've set the bar too low. All these new wonderful drugs that we've produced over the last 2 decades, and what do we have to show for it? Improved overall survival by 2.8 months. I think the bar has been set low, and we haven't made the advances in treatment that I think we would like to have made. We certainly have wonderful advances on the diagnostic side, but not so much on the treatment side. Now, along those lines, there was a major publication that came out in the British Journal of Clinical Oncology. This was way back in 2004. And what the authors did is they looked at all patients with locally advanced cancer that were going to get surgery followed by chemotherapy. And they wanted to see how much did chemotherapy, again, how effective was it in improving outcome. And what they found is that in only 2.3% of the cases did chemotherapy play a role in improving survival. And in the United States, it was 2.1%. So I think it should be clear that the standard guidelines for treating cancer, of course, it is what every oncologist will follow, or just about every oncologist will follow. We need to do better. We clearly need to do better. So with what I do in my practice now, what is my primary goal, my primary objective? My primary objective is to educate the patient. My role, of course, is to review all the literature. So I review the literature both from a conventional and non-conventional standpoint, and my role is to educate the patient so they can make an educated decision on how they want to go forward in their journey. We need to keep in mind as clinicians that we're not God, and we're also, we may be accompanying the patient on the journey, but it's their journey. And our role as a physician should be to help them on their journey. Now, if as a physician we think we're going to hurt them by doing this, of course we shouldn't do that. But I have plenty of patients that say, you know, I'm not going to get chemotherapy, and even though you may not think these supplements are going to help, just tell me what supplements are reasonable. And I often will help a patient with supplements as long as they understand what the data shows. And what I often find is that when patients come to me, very often their oncologist has not really shared the data. In other words, a patient should know if they're going to get chemotherapy using this regimen, what is the median overall survival? What's the median progression-free survival? Not quite as important as overall survival, because as in the case of my mom, when she heard the data, she said, why would I do chemotherapy? So it's very important that we educate the patient. Now, as far as what are kind of the basics in my practice, how do I practice? Well, for all intents and purposes, I practice like a conventional oncologist. I use chemotherapy, but for advanced stage or for metastatic solid tumors, I rarely use the standard of care. What is standard of care chemotherapy? It's called MTD, or maximum tolerated dose chemotherapy. And where did this idea of using maximum tolerated dose chemotherapy come from? Well, I can tell you because I've reviewed the literature. It actually comes from the 1960s and the 1970s, started with an author, Skipper et al. And they looked at leukemic cell lines. And then they also looked at treatment of acute lymphoblastic leukemia. And what they found was that maximum tolerated dose, meaning using the highest dose of chemotherapy you can, got the best results in these leukemic cell lines, which kind of makes sense because in leukemia, you typically have one, maybe two mutations, and you're basically spitting out a clonal population of just these, this one or two mutations. And so the higher the dose of chemotherapy, the more cell kill you'll have. Now, it's also based on a faulty paradigm that advanced stage solid tumors will continue to grow in a logarithmic phase. So they're going to grow exponentially. And so since they're growing so fast, you simply need to use maximum tolerated dose chemotherapy. Well, the problem with this paradigm is that back in the 60s and the 70s, they didn't take into account that solid tumors actually form a three-dimensional structure that interacts with the tumor microenvironment. And that tumor microenvironment, cross-talking with the tumor, will cause dynamic changes, both from a genetic or genomic standpoint, as well as epigenetic. And the cancer, instead of relying so much on just dividing, it really relies on what's going on in the tumor microenvironment. So the data they used way back, looking at leukemic cell lines, does not apply to solid tumors. In addition, solid tumors are rarely in the logarithmic phase. What we typically see is if we take a solid mass, we may have the outside of the tumor that is well perfused, getting adequate nutrients, and because it is well perfused, it may be growing exponentially. But then you go to different parts of the tumor, like let's say you go to the core of the tumor where there's not adequate blood supply, and those cells may be dividing much slower. You may go right to the center of the core, and those cells have such poor blood supply that they're in the cell cycle called G0, meaning they're not even dividing. So again, the concept of using maximum tolerated dose chemotherapy because all the cells are so rapidly dividing, that applies to leukemic cells where maximum tolerated chemotherapy is more effective, but it does not apply to solid tumors. So having said that, and the literature really backs me up on that, well, why is the NCCN guidelines, why are the NCCN guidelines, National Comprehensive Cancer Network, why are they still recommending maximum tolerated dose chemotherapy? Well, I'll tell you why. Because in order to change the standard of care, you need to do a large randomized trial against the standard of care, and if in fact it outperforms the standard of care, then the guidelines will consider changing. But the problem is always around funding. What entity would consider funding a large randomized trial with the same chemotherapy drugs, most of which they're off patent, so they have no intellectual property and they're financially worthless? We're just using a different dose, maybe a different regimen. Who's going to fund this study that could be $50, $75, $100 million? Well, the answer is nobody. So what will happen is we will continue to do the same thing. Actually, Dr. Timothy Browder at Harvard in the early 90s became fascinated with using what's called low-dose metronomic chemotherapy. Unfortunately, he died in his 50s of a heart attack, and so this didn't really catch on too well. But having said that, if you go to clinicaltrials.gov, you'll see over 150 publications revolving around low-dose metronomic chemotherapy that works really very differently from maximum tolerated dose. So the problem with maximum tolerated dose chemotherapy is, although you'll get a lot of cell kill, it's not just killing the tumor cells. It's also myeloablative, meaning it's going to kill the immune cells. And so when you're treating with chemotherapy, you want to have a proper balance between cell kill on one hand, but don't kill too many immune cells. And that's the primary problem with maximum tolerated dose chemotherapy. Now, in addition to that, when you're getting maximum tolerated dose, you frequently have to give long breaks between chemotherapy so you don't kill the patient. And it's during those long breaks where resistance ensues. The cancer will evolve in response to what you treated it with, but then you gave it time. You gave it a break and allowed it to make dynamic changes. In my clinic, I mostly do what I call medium dose chemotherapy, and there's some wonderful publications on that. And the idea with medium dose chemotherapy is because we've lowered the dose, perhaps around 50%, it allows us to use more drugs, which can potentiate synergy. If we have more drugs, we potentially can get more synergy. So it allows us to use more drugs and still a little bit more frequently, and it's still less toxic. Now, the advantage of medium dose is you get more cell kill than you do with low dose, so you get a medium amount of cell kill, but you're also not destroying the immune system. You're allowing the immune cells to still thrive. And there's some very interesting literature to support that this is really where we need to be heading. Now, along the lines of repurposing drugs, I use what we call repurposed medicines in oncology. And what that means is using drugs that were FDA approved for a different indication. For example, itraconazole is an antifungal drug. But it turns out if you were to search the literature, itraconazole is a powerful angiogenesis inhibitor, meaning it inhibits the development of new blood vessels, and it's been shown to be effective as adjunct therapy for many cancers, and more specifically, prostate cancer. So there are many drugs that are being repurposed, and doctors are adding them in. The conventional oncologists are not adding them in, but other doctors are adding them in. And so, again, why don't we do clinical trials on all these drugs that were developed for a different indication that really may be powerful adjuncts for cancer? Well, we do have some of the drugs that are undergoing some studies, but not nearly enough. And again, to beat a dead horse, the reason we're not funding a lot of this is because there's just going to be a great loss of money. Because the only thing that you can get out of this, a study, will be a publication. There's no pot of gold at the end of that rainbow. In addition to using medium dose chemotherapy in my practice, as I said, I use repurposed drugs. I do use high dose intravenous vitamin C. I am familiar with the literature, and based on the data, I don't think that high dose IV vitamin C by itself is a game changer, but it may potentiate chemotherapy, and based on some preclinical data, there may be synergy with IV vitamin C and some chemotherapy drugs. I also do use often immunotherapy in lower doses, and I'm much more creative in the regimen that I develop. And based, I think, on what I do, I think my success is greater than what is typically seen with standard of care. To touch on some other points like diet and nutrition. Of course, if you go to any oncologist, they'll tell you that eat whatever you want. Here, take the donuts here, take the milkshakes, it's all good. Well, you see, the reason they can say that is because good luck finding a prospective randomized trial where you have a group of cancer patients eating ice cream and donuts every day versus another group eating, for example, a Mediterranean diet. Well, again, we come down to the same thing. We don't have good prospective data on diet for cancer, again, because of the cost of these trials, and nobody's going to make any money on it. So I have to admit to oncologists, I don't have data to say whether eating ice cream and candies and cakes is good or bad for you. At least the retrospective data that we do have tends to lean towards it's not a good idea to eat a lot of sweets for most diseases, mostly a plant-based diet is probably helpful. Now, in my practice, I rarely use a ketogenic diet other than when we have a cancer that is extremely glycolytic or sugar-loving, because there's a little more data on that. Going to another modality, exercise. You know, I've done many lectures with a board-certified oncologist from Yale, and he said something in a lecture that was amusing that I'll never forget. And what he said is, you know, I would bet if we took all comers, solid tumors that are stage 4, and we randomized them. One group got standard of care chemotherapy, and the other group got a rigid exercise program, that the exercisers not only far outlive the standard of care, but they have a better quality of life. And then he followed that by saying, but who's going to sponsor that study, Nike? So there is certainly a preponderance of literature to suggest that exercise can be helpful with cancer. Again, there's a lack of good prospective randomized trials, but I definitely encourage exercise. Exercise not only stimulates an immune response, but it also turns on tumor suppressor genes like LKB1. Now, going to switching modes at this point, I want to talk a little bit about my research. So when I started my journey and I looked at the literature every day, every night, and it became an obsession, not just a passion, but an obsession, I eventually started a pharmaceutical company. What I ended up doing is bringing a drug that targets cancer stem cells to a spin out of Harvard. And we merged with them and formed a pharmaceutical company. And we recently went public. And likely the second quarter of 2023, we're going to launch the first phase 1 human trial on patients with stage 4 solid tumors with the first drug that targets cancer stem cells. So I'm certainly excited about that. Now, in addition to that, I recently completed 2 experiments at University of Michigan, and let me tell you a little bit about this because, at least in my mind, I think this may be the most promising and game-changing modality, certainly in patients with advanced stage solid tumors, and it may well apply to early stage cancers. And for that, I need to explain a little bit about the basic science of cancer. So how does cancer go from being a focal disease to spreading around the body? Well, I think most oncologists are aware that cancer cells will break off from their primary location and eventually intravasate into circulation, and then they seed, they spread around the body. But over the past few years, we've learned a little more. It's not the individual circulating tumor cells that are a problem. So when individual cells break off and they get into circulation, they don't live very long. So they either succumb to the hydrostatic forces in the vasculature or the immune system, but they just don't make it. It turns out that there are a subset of what's called tumor-associated clusters. And so there are regions within the tumor that are genomically and epigenetically pre-programmed to leave as a cluster. And these clusters are not just composed of clusters of tumor cells, but they have an entourage with them. They're often heterogeneous clusters that have clusters of macrophages, type of white blood cell that can release vascular endothelial growth factor. They'll have cells surrounding them called circulating endothelial cells, or they will become circulating endothelial cells. Endothelial cells form blood vessels. These clusters need nourishment, and so there'll often be a cluster of circulating adipocytes, cancer-associated adipocytes. These are fat cells that will nourish these clusters. So all these circulating clusters, those are the problem. So the clusters eventually will intravasate into circulation, and it's been demonstrated that these clusters have between 50 and 100 times greater metastatic potential than individual circulating tumor cells. So that is the real problem. It's these clusters. And these clusters are extremely resistant. They tend to be hypoxic, very low on oxygen, and unfortunately, our treatment doesn't work. Chemotherapy doesn't kill these very resistant clusters. So about 2 years ago, I conceptualized a technique to develop an extracorporeal device, kind of where your blood will leave your body, like going through dialysis or apheresis. And in line, we will put a filter that specifically captures and breaks up or eliminates, hopefully, every single cluster. If you break up all these clusters, they cannot reform. What's been shown in the literature is that clusters form from its origin at the primary tumor. The cells are not able to recluster intravascularly. So what we ended up doing is 2 in vitro experiments at University of Michigan to see if we can break up all these clusters. And this was an in vitro experiment. We ended up capturing a lot of these clusters as opposed to breaking it up, but that was an in vitro study. So what we're going to be doing is we're going to be doing a study at University of Florida with dogs with very aggressive advanced stage solid tumors. And it is my hypothesis that if we allow the blood to go through this filtration device as often as needed, and we'll design the protocol, and of course, if the disease starts to spread again, they can get more frequent passes through this filter. It's my hypothesis that if we can eliminate the seeding of these clusters, that we will greatly extend survival. And this is something that patients can do on an as-needed basis. So let's say we got circulating tumor-associated clusters to 0. And we can periodically check their blood for clusters, and maybe 2 months, 3 months down the line, we say, your clusters are really building up, and we're going to bring you back for another pass or more passes through this filter. Now, I said this is potentially game-changing for advanced stage solid tumors, but what we're also finding out is that in early stage tumors, there are often circulating tumor cells found and circulating tumor-associated clusters. So we can use our diagnostic techniques when we see early stage cancer to make sure there are no clusters. And if there are, we need to eliminate those clusters. So I certainly think that this is a very exciting pursuit. And of course, my hope is that I will get adequate funding going forward. One of the issues is this is not a drug where you can pass out billions of product. So the question is it financially exciting enough? But it is going to be my new purpose before I pass. I have to see this done because I do believe that this can be game-changing. I commonly tell my patients that I don't have any friends. And I say that kiddingly. I think I'm a nice guy and I have friends. But I say that because I don't like both sides. I'm not happy that conventional oncologists will not step outside the guideline, out of the guidelines, even if the treatment's not working. They will continue down the algorithm, and then they say there are no other options. You can either go to hospice, you can go in a clinical trial, but there are no options. And I think that's unfortunate, and medicine wasn't always that way. On the other hand, there are also many alternative medicine doctors that are not cancer researchers, and there's not a lot of data for a lot of things that they do. And, so I'm not in love with a lot of that too. What I try to do is I try to tell patients, I'm going to give you where there is all the information where there's a fair amount of data that may help you. Now, you as a patient can still choose to do what you want, but I think it's incumbent on me to at least impart on them where there is data that may be helpful. Now, it's also very important, and I tell this to every one of my patients, you need to be the quarterback. Even though your oncologist has your best intentions in mind, he only knows what he knows, and he doesn't know what he doesn't know. And even me, although I'm searching the literature, there are of course things that I don't know. And so I tell every patient, you can get all the consultations you want and download as much information as you can, but you need to be the quarterback. This is your journey, and you need to decide what you want to do. And again, as physicians, our role should be to help you, never to do harm. We should not give you something if we think it'll hurt you, but we should be here to support you, but you as a patient need to be the quarterback. So you as a patient, how do you navigate your path? And I think if you want to stay with your conventional oncologist, I think it's reasonable to also enlist the help of another practitioner, whether it's a naturopath or another practitioner that has experience with integrative oncology, and enlist their help as well. And you can do both simultaneously. And it's not a bad idea to enlist nutritionists as well that have experience with oncology and acupuncture, Chinese medicine. This, of course, is going to be your path and your journey, but I do not believe that you simply have to just have a primary oncologist and no other adjunctive doctors. I think it's not unreasonable to do that. Now, you as a patient, if you say, I am not getting maximum tolerated dose chemotherapy, but I will consider chemotherapy, then unfortunately you would have no choice but to step outside that paradigm and find an integrative oncologist like myself. Well, thank you all for listening to me, and I enjoyed sharing my information with you. And again, I want to thank Faith and Gratitude, and I want you to know that Faith and Gratitude also offers a free cancer resource guide to help you through your journey, and you can request that from their website. Thank you. Thank you very much.
Thank you for joining us today. You can learn more about Dr. Rosenberg and Advanced Medical Therapeutics at amtcare.com. At this time, we would especially like to thank our sponsors for making this speaker series possible. For more education and empowerment during your journey to better health, visit us at faithandgratitude.org.